All right, welcome everybody. Thank you so much for coming out this afternoon. We are very excited to have one of our alums, Dr. Johannes John-Langba here, visiting us and presenting on his work. I am going to turn it over to Dr. Sandy Wexler, who was Dr. John-Langba's chair of his dissertation almost 20 years ago now, to introduce him, and then we will hear about his wonderful work in South Africa in all kinds of creative things. Thanks so much.
Good afternoon. I'm going to keep the introduction brief because otherwise we will all be here for quite a long time. So, Johannes John-Langba is a professor of social work at the School of Applied Human Sciences, College of Humanities, University of KwaZulu-Natal in Durban, South Africa. He has his PhD in social work and an MPH, Masters of Public Health, from the University of Pittsburgh. Yes. And his MSW, Masters of Social Work, from Howard University, which also should get an A, and his Bachelor of Science in Education from the University of Sierra Leone. I'm just going to sort of skip around because there's so much to talk about that I really don't know how much I can say without keeping you here for a long time. I will like to say that Dr. John-Langba serves on a number of editorial boards, including for the Journal of Cultural Analysis and Social Change, the Journal of Ethics and Social Welfare, African Journal of Population Studies, and in addition, he is the lead faculty for public health for WebMD Central. Dr. John-Langba also has a very strong publication record and a very strong research record. He has looked at issues such as the social dimensions of health and disease, sexual and gender-based violence, mental health, substance abuse, and family well-being. He has authored 3 books, numerous articles and book chapters, and a wide number of research reports. He is a member of the board of directors and is the mental health ambassador of Cape Mental Health in South Africa. He is also the regional vice president of the for Africa of the World Federation of Mental Health, and is also the World Federation of Mental Health representative to the World Health Organization's Africa Regional Office. He serves as the co-chair of Data Ethics Working Group of the International Science Council's Commission on Data. Dr. John-Langba is the recipient of numerous scholarly awards, including Excellence in Teaching Merit Award from University of Cape Town in South Africa, and the Dr. Inabel Burns Lindsay Social Work Education Leadership Award from Howard University. Most recently, he was named one of the global top 100 most influential people of African descent by the United Nations, and was inducted in what they consider the class of 2023. I can continue on. I have another paragraph here, but I'm not going to. I just want to say that for those of you who are faculty, for those of you who are thinking about becoming faculty, in your careers, you may have the privilege of having groups of doctoral students where you go in and you think, why am I up here? I have nothing that I can really teach these people. And then you realize that you're up there so that you can learn from them. It has been my privilege and my honor to spend the last 20 years learning from Dr. Johannes John-Langba. Thank you.
Thank you, Dr. Wexler. It's surreal that I'll be standing here and you introducing me. I remember when I was stuck in Kenya, trying to get back to the US, and she got me back. I was refused a visa to come back, and have, and the late Dean, may so rest in peace. Larry was very instrumental, and it's an honor, and I'm humbled and privileged to be back here, and thanks to Dr. Wexler for initiating this, and the Dean Farmer for inviting me. I get invited to other universities, and this is the first time I'm back here in this capacity to talk about what I do and how I could contribute to becoming the university it is. When I was asked to, invited, and the dean said, maybe you want to give a talk. I was wondering, what can I talk about? And I didn't want to make this can you hear me now? I didn't want to make this, a talk about my career journey, and so it was, trying to balance what am I going to talk about. But I wanted to focus on, I'll talk about my career journey and my background a little bit. I want to talk about something I'm passionate about. That is especially in Africa, community-based mental health service provision. And I have particularly selected this organization, Cape Mental Health, where I serve in the board. I'm the mental health ambassador and vice president. It is, and I'll talk about it, it's arguably the oldest community-based mental health organization on the continent, over 100 years. And as you all know, as social workers, social work, just like in the US, came about to respond to some of the inequalities and some of the oppression and poverty among vulnerable populations in the US, and it's the same in South Africa. And I think it was established when the British ruled South Africa, and it's there. So I just want to thank the school, again, the dean, and all the faculty for inviting me. Like I said, I am humbled and privileged to be invited to talk about what I do, and not just as an academic, but at the global level, not just representing my university, because they'll definitely exactly ask about my bio for wherever you serve, and University of Pittsburgh is there. So thank you very much. Thank you to all the faculty. A lot of them have retired, and I see Kaya there. I have a fossil, that you are. But so I decided to talk about delivering community-based mental health services in Africa, and zero in on highlight the work of Cape Mental Health. But before I do that, I just want to, for the colleagues and the students here who don't know me and my background, I know Dr. Rex has talked about it, but I particularly try to list this because it's very important for not just the student, but for people to know who are the folks that contributed to what I am today. I have a PhD in social work from this wonderful university, and this awesome school of social work. The support we had here was extraordinary. I can tell you that. So, and Dr. Wexler, you don't know this, but or don't remember this. The Dean Larry Davis had just, I think, started that year, and he had a presentation of his work, and I think there was a book. And as PhD students, I'm not sure it's this room, but the faculty large, and were invited, and I was standing there, and I was standing with Dr. Wexler, and we were listening, and she asked me, so where are you with your PhD? What are you interested in? And we started that conversation. And I told her I'm interested in sexual and gender-based violence, refugee women, and just like she did just now with a PhD student. I know this person in Ethiopia, and so on and so forth, and that's how it started. Um, and at that point, Dr. Wexler did not teach me because the course that she was teaching, because I was in the joint program that year, three of us that were in the joint program did not take that course. And so we had to take the following year. So for someone who was interested in what I do and my interest, and thank you so much. And that's the topic: relationship between sexual and gender-based violence and sexual risk behavior among refugee women in Botswana, the mediating role of depression. It's straight up quantitative, and I met with Ray today. I told the dean I need to meet with Ray because he honed my quantitative skills. But that committee included, the chair, the Wexler, Ingo, Ravi Sharma in public health, and the dean. And I was for the MPH in the division of behavioral community health, and we used to do a research paper, and my advisor was wonderful, to this industry. And I had him asked, right, so please. But the training program was very instrumental in my career at the NPH. I was telling the PhD student that, which was a very important question, that how did you, only I think it's faculty, it was, how did you come to be? And I said, I read my NSW, I took a course, human behavior and social environment, and a professor that became my mentor and still my mentor, is Professor Emeritus now, Lawrence Gary at Howard, and was teaching out our essays, and I was giving it to my graduates, and he said, "Come here, you young man, come here. Well, what do you want to do after your NSW?" I think it was this last semester of the NSW, and I said, "I want to do an MPH." And he said, "Why? You're a PhD, material." And I said, "No, I want to go back to Africa." That was, more than 20 years ago when HIV was ravaging that continent, and I needed a PhD, a master's in public health to go back. And he said, "But I know, a program that does MPH and PhD at the same time." I said, "Well, it's a bit," and that's how I ended up here. And thank you so much for, for the graduate assistantship, believe it or not, I was in the natural sciences and trained as a teacher of chemistry and biology, and I thought before I left Sierra Leone, left the war and came to the US, and worked in a group home for at least 2 years. Then one day a social worker came. I was in a group home for kids with developmental disabilities, and he said, and I asked her, I think it was the third visit, she used to supervise us, look at our medication administration, and I said, "How do you become a social worker?" She had an NSW, and she said, "Well, you need to get a GED first, and then you get, your bachelor's." I said, "I already have a bachelor's." She said, "Really? You can apply straight to Howard," and that's how. And I knew it was, like we always say, social work is a calling. I said I want to be a discovery profession, and that's how I dumped natural sciences. But that is my background. Not working. Okay, I think let me do this. Yeah, let me do the arrow. So that's my background, and I'll be fast with this. I think it's very important to I will start the last my academic career really 20. Yeah, and I've swapped them over starting from usually start chronological order, but I've decided to start with a postdoc. I got a postdoc in Kenya as soon as I defended. And it was that interview that I went to before I had a defense date, and I needed to renew my F1 visa, student visa, and I went to Kenya. The international office said, "Oh, that's good. You go for an interview, you can just renew your visa there." And they gave me all the documents, and I had funding and everything, and I went, and the consular officer said, "I'm not convinced. I'm refusing your visa." And thank you, so it's not for getting me back. It was July 20, I have to say this because it's a long journey. And it was, my defense date was 8th of August, and I was there for the interview July 25th. And I had an interview at the US consulate in embassy in Nairobi, I think the 28th of July, and she refused me. And I emailed and called, "Dr. Wexler, I'm stuck. I didn't get the visa." And they didn't, and I got me back here. And I defended on the 8th of September. But I went, well, Dr. Wexler said, you need to, get another appointment. We'll get you back here. It's an online system. I went in there next day, and the earliest date I got was August 30th for my interview, to go back and try my luck again. And can you imagine the anxiety? But then she was very confident. Before I even went for the interview, she said, "We're going to reschedule. I'll check with Ray and others, and we're going to reschedule your interview, your defense to the 9th or 8th of September, I think." So I went. It was easy. They sent the document. They did with a letter. And I'm mentioning because how they did, it was very instrumental. And so I got back. I defended, and off to Kenya, and I'm not back. Like I said, this is the second time I'm back in Pittsburgh. But I didn't want to be an academic. I wanted to work in international development, as you can see. I was recruited from Kenya, came to the University of Cape Town as a senior lecturer, which is an equivalent of assistant professor. But this was attractive because I was going to do programming, and I was the Child Poverty Program Manager at the Children's Institute, doing research education that puts on child poverty. Then I went back, to Kenya to work for UNICEF as monitoring and evaluation specialist. Came back to South Africa, worked in 2 organizations, did HIV programming. Then I went back to migration, and that's how I, to 2004, because I was at the University of Cape Town till 2008. I didn't really want to be, but that's when I was reminded that I was an academic. This is very important. That's why I'm focusing on it, because when I was at IOM, then the university said, do you want to come back? This way. Okay, I think this works. So I came back in 2011. So I'm now a true academic, and I'm loving it, and I don't think I'll go back. So I came as a senior lecturer again to the Department of Social Development, which is really the Department of Social Work at the University of Cape Town. And came to the University of 2011 to 2017. I was at the University of Cape Town, and I was recruited to go and head the social program at the University of Town. I did that for 2 years, which is the second one there as academic leader. That's what I would call the chair of the department, the academic leader, and head of the discipline. And then the deputy vice chancellor of the college said, we are interested in PhD training, and we need that. So the director of the College of Humanities, Doctoral Academy, which is like a larger form of the expanded form of the doctoral program, that includes 6 schools in the College of Humanities. And yeah, so I wanted to play a video of the University of KwaZulu-Natal, which will give you a sense of what that university. I think it's very important, especially for the students in the room and the academics to know this university and what we do. And it's the largest university in South Africa, over 50,000 students, PhD, but demographics is what's important here. Unlike the University of Cape Town, that is not too different from a university in the US in terms of demographics. The University of KwaZulu-Natal is 90% Black. And it was the impetus of the motivation to go there is to impact a different demographic of Africans. So yeah, and it's UCT has its own challenges and it's here, and I'm not sure the video. It's the end slide. And the video. You guys gone? But I just wanted to play a video. I think it's a 5-minute video that's gives you an overview of the practice of KwaZulu-Natal.
KwaZulu-Natal is the subtropical pearl of South Africa, with boundless landscapes stretching from southern Africa's highest peaks to the golden sands of the Indian Ocean. Lying within this beautiful scenery is a university that strives to inspire greatness. The University of KwaZulu-Natal is a multi-campus residential, teaching and research-led university with a proud and rich heritage of academic excellence. Its 5 centers of learning are situated in the cities of Durban and Pietermaritzburg, in the heart of this beautiful province. UKZN is the largest contact university in sub-Saharan Africa, with over 4,200 employees and 49,000 students across all disciplines, including some 3,000 international students from 82 countries. Our staff are drawn from all over the world and reflect different demographics and cultures. Of our academics, more than 50% hold a PhD as a minimum qualification. UKZN is ranked as one of the top 3 research-led universities in South Africa and amongst the top 3% of universities worldwide. As a university, we have streamlined our academic sector to be more effective and responsive to the needs of our students by adopting the college model and have 4 colleges spread over our 5 campuses. These include the College of Agriculture, Engineering and Science, the College of Health Sciences, the College of Humanities, and the College of Law and Management Studies. Each college is led by a Deputy Vice Chancellor and Head of College. UKZN's Transformation Charter is key in steering our identity and culture, providing a set of transformation goals vital for achieving our vision as the premier university of African scholarship. At UKZN, transformation and excellence are closely paired, with both goals being integral to the other. Our mission is to take the lead in cutting-edge African-focused research and community outreach and to provide quality tertiary education that is available to all. In striving to offer a learning environment that is accessible to all South Africans, at UKZN, we facilitate several avenues of financial support for our student population, totaling some 1 billion rand. Generous scholarships are available for top academic and sports achievers, whilst the university works closely with the National NSFAS Bursary and Loan Scheme, as well as private and corporate donors to assist our students in need. All these factors make UKZN a uniquely South African university that is academically excellent, innovative in research, critically engaged with society, and demographically representative. As a proudly research-led university, UKZN provides a dynamic environment for all facets of research and innovation and consistently punches above its weight in the production of weighted research outputs. The College of Agriculture, Engineering and Science is at the forefront of such innovation, with its work in developing drought and disease-resistant staple crops that enable food security in Africa. From the College of Health Sciences, a gel that reduces the incidence of HIV and a skin patch that administers insulin without needles are both world firsts. The College of Law and Management Studies produces specialized and accredited professionals in the field of law, accounting, marketing, financial management, human resources, public administration, and IT. And the College of Humanities actively contributes to the intellectual development of the region through thought-provoking annual festivals such as Time of the Writer, the Durban International Film Festival, Jomba Contemporary Dance Experience, and Poetry Africa. Moving forward, UKZN has identified 4 strategically oriented cross-discipline research flagship focus areas, namely African health that aims to save lives, big data and informatics that offers relevant computer solutions for Africa, social cohesion that addresses inequality and promotes nation building, and African cities of the future, which moves towards creating livable cities. These flagship research areas are intimately aligned with UKZN's new 5-year strategic plan. Launched in 2017, the plan outlines the institutional culture, goals and enablers that will help UKZN realize its full potential as South Africa's university of choice for the country's most talented students and scholars. By focusing on excellence in teaching and learning, high-impact societal and stakeholder community engagement, targeted internationalization, and excellent and high-impact research, innovation, and entrepreneurship, UKZN aims to contribute meaningfully to the future of South Africa and add real value to all its stakeholders.
The University of KwaZulu-Natal has the power to effect change. We see it as our responsibility to cultivate researchers and produce graduates who will not only change their own lives, but also the world around them. That is how we will continue to inspire greatness on the African continent.
Thank you for watching. And as you can see, it talks about the 5-year strategic plan that ended, 2021. So it's an old video. The vice chancellor there is not the vice chancellor anymore. Have vice chancellor named Professor Nana, who's from Ghana. But why I play this video in terms of what I do, and that obviously I'm in the College of Humanities, and the College of Humanities has 6 schools, and one of them is the School of Applied Human Sciences, and that's where I'm located. But I also, the College of Humanities Doctoral Academy is at the college level. So, and so doctoral training in the 6 schools is what I was doing the last 2 years, and building doctoral research capacity. But in terms of the flagship programs, in terms of the what academics can focus on, it talks about big data and informatics. My contribution is what I'm doing as the co-chair, the global co-chair of co-data and data ethics with a colleague in China. And this the data ethics working group is a global working group that looks at ethics related to big data. So it fits into the university's strategic plan. And of course, African Health, which I am the regional vice president for Africa for mental health. So, and I think one is then asking us is fit into what you do and so on. So at that global level, not just serving, at the global level, but it has, directly engages with what I am expected to do as an academic, to be out there and contribute to those facets. But I think this is very important because the video, you understand, some of you that the faculty, even the student, what UKZN is all about and the structure of the university. We have calendar year academic calendar. From February to June is the first semester, July to November is the second semester. So if you are thinking of visiting, or even for us, then how do we fit in that calendar, also fit in the US system as well? So having said that, I just want to now briefly talk about, and I wanted to highlight this because as Pitt alumni, I mean, if you look at the first current research I'm doing, community-based response to gender-based violence, I've highlighted, Jayashri Mohanty. Jayashri Mohanty is a Pitt alumni here. She's now in Canada. She's an associate professor there at Pittsburgh University. So we are collaborating on this. It's funded by the Canadian government, looking at what really worked during the lockdown. How do community-based organizations continue to provide services to survivors of gender-based violence during the lockdown, especially in South Africa? So in South Africa, the US, Canada, and India. So that's Pitt alumni collaboration. Then I'm working on, interested in COVID-19, how family members care for their loved ones, especially those with mental disorders and neurological disorders during the pandemic in South Africa. Then during the lockdown, we decided as academics, as Pitt alumni, to do collaborative research. I led that, that process. We're looking at an investigation into the psychosocial dimensions of COVID-19 pandemic among university students in 5 African countries: Sierra Leone, Ghana, Kenya, Tanzania, and Botswana. Botswana, you can see I highlighted T. Modia. She was in the PhD program here. She was 1 year ahead of us. And she's a faculty at the University of Botswana. Teresa Kajagi was in my cohort. It's now the head of social department at a university in Tanzania. And P. Stevenson is the director of international programs at Elizabeth City State University here in the US, and was the former chair of the social program at State. Then Sandy Momba, also with just smiling. Yeah, she I think she has retired now. She's at the University of Michigan. So we decided to do this work with other colleagues at these universities in 5 African countries. But we drew on our alumni around, and we worked closely together, and it was an online survey looking at fear of COVID, anxiety, and depression, and a sense of hopelessness among university students. And we had a very hard lockdown in South Africa for nearly 6 months, where only one member of the family goes to the store in a week, and we stayed there, and how that impacted on students because we asked them to go home. So I wanted to highlight that, not just about the research, but the collaboration as well. And then, early, I think it was April, during the pandemic again, I collaborated with a colleague to just screen for anxiety among first-year students who started freshmen in February, and we told them to go home in May, and the anxiety that comes with that, and using a very simple anxiety screening to the general anxiety disorder scale. And more than half of them scored high anxiety. And we provided that information to the student support services when we come back to look at their profile, not because it was an anonymous survey, but you can tell which category of students are scoring, the age, where they live, is it in the rural area, is it the urban area, and then the collaboration with colleagues in Sweden as well. And of course, this one, looking at social media use and psychosocial well-being, basically looking at issues of, self-esteem and life satisfaction, and how that, is there any association frequency of social media use. So, and the role of body image. So those are the current research. Quickly talk about this, and then I'll be quick. I just want to highlight what this organization does as the vice president and mental health ambassador, but not just keep mental health, but community-based organization and what they are doing. And they matter in Africa because a lot of governments are failing us. So they contribute significantly to the provision of mental health services. A community-based organization calling CSOs. And often in dire socioeconomic conditions and resource, they provide a resource for communities. And I will also do a short video and you see what I'm talking about. They are usually formal, they are regulated a little bit more. Most times they are informal. Very little regulation and legal framework. And their role remains vital. But what they particularly do is what we call parallel interventions. Is, they not only provide mental health services, they try to address socioeconomic conditions as well. So you can't just, as an NGO or CDO in some of the communities you work and just provide services. You have to provide food. You have to address other issues as well. But their role really came to fore when during the COVID-19 pandemic. As the vice president of the organization, I had to record a message to motivate the staff who are working out remotely, fearing for their lives as well. But someone is a survivor of gender-based violence, COVID or no COVID, you have to provide services and help. And that's that research with Ashley. What really works, and provide that evidence for our recommendation for future public health emergencies. So we know exactly it's not just about doing remote counseling, because especially in South Africa, well, I don't want to reinforce some of the stereotypes, but South Africa is considered the rape capital of the world. And femicide rape is right. So, and during the lockdown, apart from rape or just domestic violence, and I mean, it's not too different from the US as well, where people are locked in with partners they don't want to be with. And in South Africa, we banned alcohol and cigarettes for nearly 3 months. And you know what that means, So the anger was taken out on women and their partners. So I was telling one is that it was so bad that people wanted alcohol and they dug a tunnel, underground and entered into a liquor store. So it was after the 3 months at one part of the city when the lockdown was lifted and the owner of the store went and saw people in the store just to get the alcohol. And cigarettes as well. The minister in the presidency who was in charge of COVID-19 mitigation measures banned cigarettes. She's a medical doctor. She's against big tobacco, and it was an opportunity to ban them. And they came after her, death threats. And this is your Philip Morris, these big corporations around in the US and in the UK and Europe and in South Africa. But the mental health impact of COVID-19, some of these organizations that keep mental health, had to do something about it. So sometimes they are not structured, they are largely driven by their mission, vision, and objective. And we employ a human-based, right-based approach to whatever we do. But there is still that unequal access because of the inequality and in most African countries, not just South Africa. But what some of these NGOs do, like mental health, we try to hold governments accountable to provide services. I was talking to colleagues this morning about in my role as the regional vice president for Africa. Tomorrow is World Mental Health Day, and I'm supposed to have an event. During the lockdown, we have, and I will continue with that. We used to have face-to-face webinars and just promote mental health awareness. We're going to have a webinar on suicide and suicide prevention and the decriminalization of suicide in African countries. Half of the countries that still criminalize suicidal ideations and attempts in Africa. Not to name and shame, but Kenya, Sierra Leone, Nigeria, Tanzania, Malawi, Uganda. It's a crime to even think about taking your own life. And it's a problem. It's a problem. It's a barrier for access to services because, you know, if you talk about, you know, how you're feeling, you go to jail, and even family members will know every report. You know, if you commit suicide in some countries, and that's the law we inherited by the colonial, I don't want to call them masters, but the British in particular. So these laws are still there. And to the extreme that people that commit suicide in some countries are handcuffed and buried with handcuffs. So my webinar on the 25th is to highlight that and advocate for countries to decriminalize suicide and suicide attempts. And a lot of countries, Ghana has done that in 2021, changing legislation. So other African countries. And it's not just in Africa, you know, Singapore just did it, Pakistan this year, Guyana, because it's not helping us. It's not, you know, but you know, the bigger picture is, you know, there's rising prevalence of suicide among people in Africa. And some of the research we're doing, body image and social media, it's a problem. So we need to start addressing some of these. And so Cape Mental Health that I'm highlighting, is to, you know, like I said, arguably the oldest mental health community-based organization on the continent, at least in sub-Saharan Africa, and rose to the occasion by providing, I think it's only in Cape Town, one of the very few organizations that continued to provide services to survivors of gender-based violence. So just to talk about Cape Mental Health, where is a riveting.
Today is an ordinary day in the lives of the 4.5 million people living in the Cape metropolitan area. Most parents wake up their children to go to school, and those who are employed leave home to go to work or busy themselves during the day. Unbeknown to most, over 1 million of these people have already experienced or will face a mental health challenge that could impact the course of their lives. Without adequate support and mental health care, these challenges could become too great to overcome. Today we will follow the steps of 4 people whose lives have been impacted by mental health in some way and who have walked the journey with Cape Mental Health. Stay with us as we spend the day in Mitchell's Plain, Khayelitsha Observatory and Gugulethu and get to know more about Jordan, Pamela, Grant and Simtandile. Jordan Marshall is a 16-year-old teenager who was diagnosed at 6 months with spastic cerebral palsy. Jordan lives with his mom, Carmelita, in a masonette in Mitchell's Plain and attends Erica's Special Care Center for learners with profound intellectual needs.
So Jordan doesn't walk at all. Jordan is buggy based, wheelchair bound, if I must put it to you like that. It's very difficult with Jordan because we are living in a masonette. So we have to currently carry Jordan up and down, including his chair, his buggy, because when he's downstairs, we need to get the chair down. When we're upstairs, we need to get the chair upstairs.
The school comes to fetch him.
They do, and they drop him. We get up by 6:30. Then he goes to his chair. Then I come down, but Also with Ericus, they have a transport group. So I can follow the driver, so I'll see exactly where they are. So then I'll come down, make a stay, then I'll start getting ready for school, you know, dressing, washing, dressing. Then myself and my father will bring the chair down. And then so 2 minutes after that, then they're here, then we'll take him out. And then whoever's on the van, whatever carer, they will take him.
Cape Mental Health provides a range of community-based services for people with intellectual and psychosocial disabilities. We offer special education care centers for children with severe and profound intellectual disability and skills and training work opportunities for youth and adults with intellectual disability. In addition, we offer counseling, psychosocial rehabilitation, and peer support interventions for persons living with psychosocial disability.
I am Jamie Schools, the program implementer at Erika Special Education and Care Center. Erika Special Education and Care Center is one of 3 centers based in Mitchells Plain, Heidelberg, and Khayelitsha. We offer special education, holistic care, and stimulation to learners with severe to profound intellectual disabilities to ensure their right to quality basic education. So without specialized transportation, that is where the driver and the caregiver goes out to disadvantaged communities to pick up learners and bring them to the center. When our learners arrive at the center, our buggies is outside waiting for them. So our caregivers assist each other in putting them into the buggies as well as strapping them. Then when we get to our classes, there's ramps available to assist them in entering the classes. Gross motor skills promotes body movement as well as brain development. It is also for the learners to release energy. So examples for that is running, jumping, and walking. We do activities like massaging. That is one of our main activities. So that is where the caregiver uses some cream to massage them, just for the muscles to be made a bit loose.
Next, we visit Pamela in Khayelitsha, a trainee at one of Cape Mental Health's training workshops unlimited.
My name is Pamela and my surname is Twari. I'm living in Khayelitsha in Mackay. My family is fine. It's like a small family, but and a nice home and a nice mother as well. But the father is not living with us.
I work at a creche. The name of the creche is Little Star Educare Center. What I do there, I do general duties like cleaning the toilets, cleaning the kitchen, making sure everything is in its place, and just making sure that it's safe for the kids. Little Star is in Khayelitsha. School was very hard for me. I had challenges with reading and writing. I stopped going to school at grade 5. Then I stayed at home for a very long time. I was 18 when I joined Training Workshops Unlimited. It was very nice for me because I was around people who are similar to me, who have the same challenges as me. So it was very, I felt free and happy to be around those people, and I understood the work that they were doing there, because we were doing work that requires just our hands, so I could do that easily. My job coach, Ms. Onaba, told me about this opportunity that wanted people to go work outside.
In the interest of time, I'll stop and I'll share this video, but I wanted to leave some time so we can ask questions. The goal was to give you a sense of the context of where we work and what we do. There are 4 case studies there. But I mean, like I said, this is what I was doing in Maryland before I went to grad school. So I relate to it. It's an organization. I worked in a group home, and some of the things we took for granted. And this is not state funded. This is a community based organization. It's a member. It's actually Cape Mental Health Society. You know, in terms of just promotion, we say Cape Mental Health as an organization, an NGO, but it's a member-supported organization, and a lot of the funding it's through grants and so on. Some of the things we take for granted. But I think one of the most important, and this is what an ambassador does. I'm one of the mental health ambassadors. I'm not just the vice president of the organization, which is a ceremonial role. But to highlight the dire need for funding and for what they do, just to continue doing this for over 100 years. It's not so. But I want to pause so that I can answer a few questions and then we can move and talk about it. Yeah. But if you were, definitely thinking of, and this is in Cape Town, I interacted with them. I used to take my senior class to this organization. It's one of the placement that if you have a student, not just in Durban, who is interested in work with kids with developmental disabilities, this will be one of the placement or internship or free practice placement. Eventually, that's the goal. For even NSW students who want to go to their internship, they can be placed there as well. In Durban, the Department of Social Work has its own community-based organization. It's called UKZN Community Outreach. We have our own building. I hosted students from Michigan and were placed there and worked in the facility, but we do outreach as well for 2 weeks. So that's really important. But if you can always, there's this, if you want to donate, everyone deserves to fly. We have a kite festival and we can fly a kite. But I think the most important thing is to highlight really, and that's why the role that community-based organizations play in bridging that gap. The states don't really, most African countries, I think less than 1% of the health budget goes to mental health in African countries, and one of the things we've been advocating is to increase mental health, a greater investment in mental health, the mental health of Africans. So, otherwise, I would take some questions. So thank you very much. I hope this gave you a sense of what I do and what I've been doing. As Dr. said, there's a lot that we can talk about. But as we continue this collaboration, we get to know what we do and how we could contribute to, and obviously how I also can contribute to this social. So thank you very much. Appreciate it.
Good to see you again.
I know.
It's been a long
I was saying, is that
Yeah.
the same Kaya I know?
Do you know until this moment, I didn't put the 2 and 2 together
I need to
until
send
I
you
saw
that
you.
photo in Andre's apartment when we had that party.
You're putting out all the secrets. It's good to see you. Well, we can talk more at dinner because I have a longer story about this, but I do want to ask you a question. So I presented at a conference in South Africa. I think it was in Cape Town a few years ago. And it really resonated with me because I was presenting work on the importance of training people in the community, lay health workers, peer educators, in brief interventions for mental health to sort of build capacity within communities to help deal with mental health concerns, and particularly in areas where there's a great amount of stigma. Without even really realizing it, it was really interesting. If this was the room and I'm here talking, sort of one half of the room were social workers, psychologists, counselors, people who went to school to be trained to deal with mental health challenges. And on the other side of the room were traditional indigenous people who it was their birthright. They were born into healing roles. And it kind of created this really interesting, I call it an argusation. It was tense, but like it was a good conversation. But one side was saying, you haven't been trained, you didn't go to school for this is what I went to school for. We need to be moving more in this direction. Whereas folks on this side of the room were saying, hey, this is my role as my birthright. I was born into healing. I was born with this. I don't need to go to the traditional school to get this education. And it was sort of clear that some, collaboration and engagement between these two groups probably would be beneficial, or, maybe even the ideal situation. So I was just curious, from your perspective, do you still see that sort of tension between sort of people who go to school to be trained to deal with mental health concerns, as opposed to what's happening in their communities and the villages with folks whose community sort of part of their life's work and their birthright is around healing? And do those two groups come together in the organizations that you work for?
Oh yeah, I mean, they call them sangumas. They're there. It's a calling. I mean, young people just wake up and they dream and they said, I'm dropping out of college, I've been called to be a traditional healer. And so what some of us are doing is to try to value their role and try to incorporate indigenous knowledge systems into the response, as opposed to, and I mean, there's always this tension even with psychologists and social workers, the medical model as opposed to what we do. So, and it's big in South Africa, how they respond and the belief systems as well, and the stigma. In South Africa, is that where traditional healers are involved in mental health. In other African countries, no, some of the mental illness is tied and to a tree in the forest and left for dead. And so, but there's also a huge problem with stigma, which we have to address, mental health stigma and discrimination. And for some of you who work in immigrant communities in the US, a lot of African brothers and sisters are so scared of the stigma because of the culture. And there's a recent, I mean, you probably heard about it in Ohio, where the 25-year-old son in Columbus, this last September, this shot both parents dead. An African immigrant since 25, he had mental health problems, and I told folks that the system failed everyone. Health and Human Services in the state of Ohio, it was in Columbus. Drop out of college, in fact, but the bottom line is, the explanation is it was stigma. The parents never talked about it. Their last son, who's now 25, started, I think, at 18, had mental health issues, had conflict with the law, used substance, threatened the dad with a gun, and smiled about it, arrested, released, never got treatment. But I think it's, believe it or not, the dad was a social worker. Did his MSW. He was given a restraining order because of that incident where he was gone in his dad's head, and they were so fearful of him, had burglar bars, and one day as a mom, on Sunday, the 13th of September, he called and said he's hungry, and I said, come. Met them in the kitchen and shot them. Got into his car and left, and he was being arrested. But the explanation really is no one knew, the extended family, because of the stigma. So it translates to immigrant communities here. In Africa, we've not, mental health literacy is something that I am passionate about, to educate people about mental health. I was telling our neighbors, somewhere else, that there's no word, at least in my mother tongue, for depression. It's crazy or mad, you are crazy, but different categories of depression, anxiety, there is no word for that. So until we start, and it's the same, not just with African communities here, but the stigma and discrimination in mental health is a problem. But the traditional healing has definitely play a role, and they've been recognized now, but and it's a mismatch because they are being recognized, well, trying to recognize them in the South African Medical Association, Medical Association, but they are reluctant to recognize them. You know, so yeah.
So what does mental health treatment look like? Do people go in an office? Do they get diagnosed? So finally they come for services. Does that mean that they're pretty severely, like the conditions are pretty severe there? It's inpatient, or what does mental health treatment look like?
Yeah, I mean, at least South Africa, you know, has a couple of mental health facilities that people can go with. But a lot of the funding is directed towards forensic mental health. So, and those are the facilities that are funded where you commit a crime and claim a mental health defense and you send to a facility. I had a student who did this research on how we integrate, you know, mental health condition who have served their time in the psychiatric facility to come. But there are very access to mental health services. Some countries there's only one psychiatrist, one mental health nurse. You know, at least in Sierra Leone, I know there's been only one psychiatrist for a very long time. But it's organized. That's why I'm focusing on organizations like this, where we have psychiatrists on call, we have psychologists, we have mental health providers, occupational therapists, children with mental disabilities. But you know, for you, if you have one mental health, you know, facility for South Africa has 60 million people. So really, I mean, South Africa is on the high end. I mean, some countries don't even have. But I think just being literate about mental health. We have a paper that we did, so we reviewed the concept of mental health globally and what people are saying what it is, and it's part of my application. It's really interesting. It's a scoping review pretty much on what has been published around the meaning of mental health. But and there's a study that someone did trying to understand mental health as a terminology, different African languages, and that's what I'm saying that some languages don't even have a word for depression or anxiety. But what we are doing is a lot of this. I mean, we have this argument. You know, we're trying to decolonize service provision, but a lot of the screening tools are European, American, and English. So we've had this debate with colleagues. I'm saying, okay, we're gonna get there, but what we need to do now, okay, we make use of what we have. And so I always insist to translate, for example, the general anxiety disorder scale into and test its reliability. And then so we can continue to, you know, when I did that rapid assessment, anxiety among first freshmen, our university, it's not bilingual, but a lot of times Zoom is also official. So we had, you know, it's an online survey. We asked students, do you want to answer, you know, the survey or the questionnaire? This is Zulu or English, and you can click and you get this is Zulu. And we made sure that, you know, which is what Dr. Alexa taught me, to do translation, you know, scientifically by having the English instrument be translated into isiZulu, right? And back translate it into English and test its reliability before you can really screen. So we did that, and obviously reliability was very high, you know, and we presented that findings at a conference in the UK. Just it's a descriptive study But what people were interested in is that the two. That was his Zulu. And they came up to us after that to say, guess what? In London, we have, I've seen probably 100 Zulu speaking who are coming for services. But I'm screening them using English, the English too. Can you, so we told them, we need to publish it and it's peer reviewed and we can give it to you, but they wanted it. And they said, we need to be doing this because, when immigrants are in the UK and present mental health condition, want to screen them for depression or anxiety, and these are literate people who can read in Zulu and complete it. And it's different, I can tell you. When you answer a screening tool, complete a screening tool in your mother tongue. So we try to do that until some of us are at the point where we can try to develop our own tools. But we need to use what we have by translating them as much as possible systematically. And I know you had your hand up before.
Yeah, and some of what was discussed kind of answered what I was thinking about. But one of the questions I did have, you said that you had a clinic that is attached to your school. Did
Yeah.
you say that? Yeah.
Well, it's not. It's like what? An agency.
An agency
Yeah,
attached.
which we registered.
Yeah. So you have your school of social work and you have this agency.
As
Right.
part of our community outreach, and it's called UKZN Community Outreach and Research.
And how does that work? Do you bring the classroom into the agency? Does the agency come into the classroom? I mean, how does that work together? Because that seems like a dream to me.
Oh yeah, it's the city of Durban gave us a building not too far from the university, and I think it was created by someone who said, I'll give this to the city when I die, and so it's been there. So they lease it for $1 for 5 years to us, and it's a very, I should have played a video. It's very nice, and we double as social workers in there. So sometimes at one point I was the director of the community-based organization, but and we can't provide our services, but we can what is needed in the community. If it's after school care where kids can come, it's a whole house. It's a big house that someone donated.
Sounds like Hull House.
Yeah, it has like 6 rooms. It's one of those colonial, Durban was colonized by the British. It looks like it's an vineyard, but we have it there, and after every 5 years, we're registered as an NGO, and we apply for grants, and sometimes when we hire a full-time social worker, sometimes we don't, and so like when the student from Michigan came, I was the social work supervisor, but these students were going into communities, or the kids came, because mostly it was kids. So come to the facility, it's like an internship, provided that service. So we usually apply for funding to the national lottery. If we can get it, we get it short time. Then there's a community chest that funds us, and the rest of it, that's as academic, we have our day job. So
You have your day job.
yeah, and sometimes we don't have time to respond to grant or release funds, but it's there. So it's one of the facilities that I think exchange students can be there and just assist us, and I can supervise them. I remember there was when I was working for IOM, there was a student from Canada who was interested in migration issues, and the university, I think the University of Calgary School of Social, contacted the International Mission of Migration in South Africa to say, we have this student who wants to do his, but I think it's on community development and social work. But part of the program is to do an international internship. But they had a problem, and they're emailing the director of IOM at that time. And they said, they need someone who has an MSW to supervise this thing. And back and forth. And he came to me, he didn't know, Dr. Langba, he didn't know how. I said, by any means, do you know someone who has an MSW? I said, and believe me, it was like the faculty in Calgary, it's like you found a diamond. Oh, wow. When I told him, so he came and I supervised him and I did everything. They had an online supervision system where I report on what he's doing. So having someone, and especially we're talking about CSW, so if a student, so you have to have someone who is there who has, an MSW as well to supervise if they are doing a, they're field listening there for the MSW or even under that. So, and I know that's one of the things, even the colleagues there, I'm not sure, because they got their MSW in South Africa, where I CSW allow them to supervise, but I am there, can not necessarily directly supervise, but be sure that it's happening. And that's why I'll be talking to the dean about how we can move this collaboration forward. You're excited.
Yes, we are. We're glasses over here.
One more question, and then Johannes and the dean are going to talk about how we can move this forward. So, Daniel, final question.
In terms of providing mental health care to people, I know in Africa, church bodies play a big role. Except for some countries, it has a negative or positive relationship. And I'm wondering, in South Africa, what is it like? Is it good collaboration, or there is also friction between church organizations and providing mental health?
Yeah, and those are two. So there's this you have a word for it when you say there's a friction. Or there is the traditional healers. Then you have spiritual church, not just your traditional Catholic, but you have spiritual churches who sometimes don't even have a facility. They're out in the field, they wear white, and this is what they do. They pray on people who have mental health issues. So there's that tension as well between the three. But I know majority, especially in South Africa, in other countries in Nigeria, it's mostly the church people. But in South Africa, it's the traditional healers is tension. They believe in sangomas, valued and valued because and it's a belief system. How do you but I've spoken to a lot of people who can't just discount it. We need to find a way to incorporate the indigenous knowledge into what we do. Whereas in other countries where you don't have the spiritual, the traditional way of dealing with it is to tie you up to a tree in the forest and leave you there. But it's not just a church. At least in West Africa, where majority of the population in most countries are Muslim, the imams also do that. They pray on people, they give them, holy water to drink and heal. But no one has actually evaluated that, but there's still that tension as well. But I think the most important, and that's what I'll be talking about in my advocacy work, is African countries to increase investment in mental health. Globally, Europeans as well is 5% of the national health account. We are less than 1%. And not because we don't have the funding, it's because we don't. It's always on the back burner. We don't prioritize mental health. It's I was one of the colleagues who also received the most influential people of Africa recent award, probably was some of you follow Nigeria. There's they call her Africa's most famous shoe. She, during COVID and everything, she's in the online space and everyone knows her. She cancelled remotely and she was telling me, I have big clients. I have famous clients, you believe it. I won't name names, but I have famous clients. So which means politicians, celebrities, go to them. And she's a psychiatrist. And lastly, at least in South Africa, okay, we talk about access to services. But the rich self-medicate. And it's a problem. And I know the problem even here. So and prescription, because you're rich, you can tell your doctor, to prescribe antidepressant. And I understand, it's prevalent among rich women. And I know a colleague told me, I'm stressed, I'm driving. The next thing is I have my antidepressants in my bag and I pick it up and I self-medicate. It's a big problem. It's a big problem. So you would imagine, some of the medication are supposed to go to people who really deserve it. People are self-medicating and they self-diagnose as well. Oh, I have bipolar. And they call the doctor. And the doctor prescribes. But those are some of the issues. At least in South Africa, in all African countries, I don't think they can afford to self-medicate. But in South Africa, where we have they reach 10%, they self-medicate a lot.
Thank you very much. And for any of you who want to get in touch in the future, it's very findable on the web.